Brilliant, Brad. I mean, markets and trends are always shifting, especially now we're going into 2021 and we're going through a new economic transition. And primary healthcare, the market in the US is exceptional. 17 and 18% of, bankruptcies in the US are related to the lack of primary care, which is amazing. And the revenue forecast for 2027 is around $410 billion, which is almost half $1 trillion market. So, incredible opportunities. I'm very happy that you've targeted that market. I know you also have a presentation to go through on your growth strategies for 2021 and beyond, which is going to pull that up. And then I think me and Hammy are going to disappear, and then we'll be back once you're done.
Yeah, and you know what, you brought up a really good point, which is, just looking at the primary care market, right? And as we talk about, why primary care is such a core aspect of U.S., sort of from a U.S. investment thesis perspective, because, one of the largest trends that we're seeing on the U.S. side now and in healthcare in general is the cost of healthcare. And especially when you look at it from the cost of unnecessary emergency room visits to surgeries to procedures that could otherwise be avoided if, let's call it the market was focusing on prevention as much as they were focusing on treatment. And much of this falls back to the primary care physician. So, it's sort of an interesting stat. Primary care might represent less than 10% of the total healthcare spend, but they control almost 60% of it. And so when you look at the comparison to what impact primary care has on the rest of that, you call it a $500 billion market on primary care. I call it a multi-trillion market on healthcare. It's a significant chunk out of the healthcare system. And so this is why we believe it's so important to focus on the market we're focusing on, because in the next 2 to 3 years, this is going to be an enormous explosive area for growth. And anyone who's playing in the space today, setting up that infrastructure, is going to recognize that participation in growth. So, these slides that I want to kind of highlight here for you is very much indicative of sort of some of that some of that modeling that we're seeing. And this was actually brought to us by our banking partner in the U.S., Oppenheimer, that we've been spending time with and spending non-deal roadshows and meeting with U.S. institutional accounts. And they were nice enough to put this together to help us also depict how the U.S. market is unfolding in general and where Skylight Health plays. And so I'll take a few minutes here just to go through some slides in high level, of course, but just to outline why Skylight Health is doing what we're doing, but really why the next 2 to 3 years in this market is really going to be the area for growth in U.S. healthcare. So as you can see here, I want to highlight some quotes from you. So these quotes are from some of the big insurance commercial payers out there, like Optum, Aetna, and Humana. And as you can see from these quotes, they're all claiming and they're all pushing towards what we call as value-based care, right? And for those that might be unfamiliar with that terminology, this pay-per-value model is typically in the U.S., in predominant forms of medicine today, in primary care, you go on a fee-for-service based model. So it's encounter-based. Doctor gets paid every time they see you. In a pay-per-value model, the payers are trying to say, look, physician, we'll pay you on some sort of a per member per month or higher incentive model so that you're incentivized to do more for the patient, which means that rather than just treating them every time you see them, prevent issues which will later cost us more downstream if these patients were to become part of a hospital infrastructure in terms of avoidable issues, let's call that, right? And so certainly the trend is moving towards value-based care, and payers are trying to think about how to move physicians from a traditional fee-for-service model into this kind of value-based model, which is going to save a ton of capital downstream on healthcare costs. But as you can see from this graph here, still over 83% of physician participation is still in the fee-for-service model. So this is not something that's going to happen tomorrow. This is something that's been going on for over a decade, but there's still a lot of wood to chop. And so certainly we are going to see the impact of that as we continue to go. This next slide that I'm going to show you here is just kind of identifying the value here in value-based models. Like, what does this really mean from a revenue perspective, from a model perspective? So I'm going to highlight here the fourth category that says PMPM rate, which basically means per member per month. And so these payers are shifting from, say, paying you every time the patient comes in, right? So the average visit with a primary care doctor is about $150 on reimbursable rates. And, if you say a patient comes in 3 to 4 times a year, that's $500 to $1,000 a year. Well, what the payers are trying to do is to incentivize physicians to actually spend more time with their patients to save that cost downstream. The benefit in that for the physician is the higher remuneration. So if you look at here on Medicare Advantage, for example, which is a well-known sort of value-based product from payers today, the average revenue on a Medicare Advantage product is nearly $1,000 per member per month. So you're talking not about $1,000 a year, you're talking about $12,000 a year. Even if you look at managed Medicaid, you're still at $6,000 a year. So you're talking about a significant improvement in revenue potential by being able to participate in these value-based contracts with payers, which they're all shifting towards. And as you can see again from this slide, just on that graph, over 56% of physician practices are still owned, which means that we're talking about small practices that need to develop these value-based capabilities in order to contract with payers on those terms, which many of them just don't have the capacity and infrastructure and time for. And so what you're seeing in the market today are kind of a lot of big name companies starting to move in this direction, right? So Oak Street Health is a company we speak highly about. And Oak Street Health has done this successfully, where they have organically, or de novo, gone ahead and set up offices, and they are organically recruiting patients into what they call as Medicare Advantage products. And so, if you look at Oak Street's model today, got about 97,000 members, but their revenue on average is significantly higher per member. And so they're at about, call it $1.3 billion in revenue. The same company, Cano Health, is doing this by way of acquisition. So this company actually just merged with a SPAC and will be coming to market soon. But look at the valuation difference between the two companies. And here's the difference. Cano Health is growth by acquisition. The difference between Cano and Skylight, though, is Cano is going and buying these existing value-based clinics. And because they're buying something that's already at the finish line, they're paying significant premiums for these acquisitions. And I'll show you what that is on the next slide. But before I get there, the only way they can continue to grow, because that organic growth has already been reached, is more acquisitions. And so you keep paying up, and paying up. Plus, everybody's focused on that market, so it's getting more and more expensive. So here's this market of managed care where everybody wants to be in, everyone's buying these practices. And then here's this entire market of fee-for-service clinics that has the potential to transition to managed care that nobody is playing in. And so this is where Skylight Health is creating its niche. Skylight Health is going into this fee-for-service market where it's able to find smaller practices, but priced at 3 to 5 times EBITDA, and is organically putting that infrastructure to convert them into managed care, so that in the next 2 to 3 years, the ability to contract in managed care could mean going from $1,000 or $500 a year per patient to $6,000 to $12,000 a year per patient. And we're doing it organically. And that will allow us to receive a multiple like Oak Street does, which is a multiple on revenue. And that is really why the Skylight Health story is resonating so well with US institutional investors, because we're taking a different approach to value-based care markets, but is giving the result in value to shareholders as opposed to paying for that value up front. And just to kind of highlight that, look at these multiples paid today on managed care companies. You're talking about an average of 14.7 times EBITDA for large transactions, and about 12.3 times EBITDA for mid-sized transactions. And so even if you look at it a few years ago, that multiple was about 9.5 times. So you're seeing this market becoming more competitive. Companies like Cano Health are going to have to start paying higher and higher EBITDA prices, whereas Skylight is able to take the same capital, acquire more practices for a lower cost, and then ultimately bring that result back to shareholders. Because in our model, again, it's fee-for-service clinics that we acquire, similar to the ones that we just announced recently. We build those value-based capabilities by bringing in our technology and data analytics and the ability to bring clinical leadership to institutionalize the way these clinics practice. And then we're able to then identify patient populations that can benefit from various value-based models or contracts with large payers. This then gives us the leverage in terms of patient population, provider population, to go in and contract with providers on these kinds of models where we can switch from fee-for-service to now per member per month, which is far improved from a per revenue unit economic basis per patient. So, this again is just a quick highlight of some of the feedback that's been received in terms of our marketing, why we are focused on this market for primary care practices, but specifically in this sort of fee-for-service based environment, so that our multiples are at a discount to where the market's at today. But the market will reward Skylight for the ability to make that conversion into that value-based market. So, certainly happy to keep going from there, guys, but just wanted to share this with you. And thank you for letting me put the slide up and go through it.